There is definitely no shortage of numbers to run through the Lombardinator. Good morning, Doc.
Good morning. How's everyone doing today?
We're just trying to make sense of the new normal, is what I coined the phrase. Yeah, Doc. I mean, I don't. How are you doing, Bree?
I'm okay.
I think everyone's just trying to grasp everything that's going on now, right? So we've got, obviously, high triple digit cases, more into the thousand side than the hundreds. We've got GDOE and their own metrics saying that it's high risk right now. They had to do away the car score because it was just too crazy looking during this Omicron surge. And I'm sure that you've got some interesting stuff with the data and what it's going to show us this morning. So do you want to get right into it?
Yeah, sure. We can jump right in. Just to set the stage again, looking at, I don't know if you guys have access to the slides, Jason?
Yep.
Okay, great. So last time we got together was 3 weeks ago, and this is what we look like. We were down here, one of the best in the nation. We're a little bit behind in the Omicron curve, and I was optimistically hoping that we wouldn't see the worst of Omicron. And this is 3 weeks later now. You can see again, let's dance back and forth here. Last 3 weeks ago and today, so now we're one of the worst in the country when it comes to the number of cases we're seeing per capita.
Sorry, Doc, real quick. I don't think you're. Are you sharing your screen right now?
Oh, okay.
Okay.
Oh yeah, here we go.
Oh, there we go.
Yeah.
Okay.
All right. So this is 3 weeks ago. Again, we're down here, one of the best in cases per capita per day, or on average. And so, and then 3 weeks later, we look like this. There we go. So we jumped through, and we're now at one of the highest rates. So per capita, getting around that 400 cases per 100,000. That's why we've been seeing case numbers, the 700, 800s here. The good news is that the case fatality rate, so the number of people that die out of the total number of cases that we're identifying, has continued to decrease with the Omicron wave. This is this part way off to the right here. So early in the pandemic, a lot of people were dying of the people that we diagnosed. It decreased a bit during the Delta wave because of vaccinations, and it's decreasing even more because what we know about Omicron, that it's just not as, it doesn't appear to be as severe. People are still dying, going to the hospital, but not proportionally to where they were before. And compared to the rest of the U.S., Guam still compares pretty favorably in this area in the case fatality rate. Down here, you see definitely some states doing much better than us. Hawaii is still, despite their recent surge, their fatalities per capita are still much better than Guam's. This was 3 weeks ago too. I showed the 10. We were one of the 10 best states in the nation, and I wanted to compare New York at the time because they were one of the worst in the nation. And so we're going to fast forward here. So we kind of flip-flop with New York again. I kind of in jest, I said we seem to flip-flop with New York when they're having a surge. We're not that it means anything, but it's just interesting. So New York is coming down significantly from the surge, and while we're sort of coming up to close to our peak here. So, even in the worst states and countries, it's rare to see them get over this number of 400, 450-ish cases per 100,000 on average. We're going to zoom in here. This is just the last 4 weeks, and you can see, the last 8 weeks. You can see New York surge started around the middle of December. They peaked about 3 weeks later, and now they're 3 weeks after their peak. So we started our surge about 3 weeks, and that's been more or less the picture that we're seeing in many places. It's taking about 6 weeks total to get over the hump and back down again. Some places are still not coming down, but for the most part, I think that is a reasonable expectation if you want to know what we're going to be seeing here. I would like to think that we are at or near the peak. If it goes up much higher, I don't see us going much past maybe this level here, 500. I still don't have a great explanation why we always seem to be more at the extremes of what we're seeing everywhere else. But it's also possible that we're capturing more cases than other states. I think that's possible, even though we sort of have this impression that it's very difficult to get testing here. Maybe it's actually a little bit easier for people to get tested than other locations. And we're comparing Guam to states, which isn't fair either, but still. Now, so here's some examples where, Hawaii, they kind of started this slow, gradual Omicron curve about the same time as New York. but they're still not really coming down that fast. So, you know, that 6 week doesn't really hold true for them. Rhode Island still is kind of up there as well too. So, you know, what happens to Guam, how fast we're going to come down, I think does remain to be seen. But, you know, optimistically, it'll be about a 3 week tail end here. Just pulled one slide from the Dr. Pobutsky's presentation just to highlight the fact that, you know, it's the younger age groups, 12 to 17 and 18 to 39, that continue to drive this Omicron surge. And it started with the 18 to 39-year-old group, and that has sort of more spread to the age group below that. So, in the U.S., the CDC published this. They call this the nowcast. This shows how much is Omicron. Delta is orange here, and you can see the rapid shift over the course of about a month's time to essentially 100% Omicron. And even if we're about 3 weeks behind the rest of the U.S., we're still, you know, I think the vast majority of what we're seeing here in Guam right now is Omicron. I'd say it's at least 95% and maybe even up to 100% Omicron right now. So thankfully our hospitalizations are still not looking all that bad. We have come up to over 30. I think GMH is in the 20s by itself between the three hospitals. I think this is manageable as long as the rest of the hospital census, you know, we're nowhere near the peaks that we were seeing in the Delta wave. I mean, just it's scary looking at how high we were for how long we were at that level, and our ICU numbers thankfully have been very, very low as well. So I was thinking with this Omicron wave, we might get to 50 hospitalizations, and that still may be the case. We might even go a little bit higher than that. As we know, the hospitalizations are going to be delayed a week or two after the cases. So if hopefully, if we're peaking in cases right now, we still won't see peak hospitalizations for another week or so. So we've got that to look forward to. And obviously, a massive thank you to the folks working in the hospital to keep our people safe there. It's still pretty appalling how many deaths we're seeing in the United States. We're still, you know, in that 2,000 to 4,000 people per day in the U.S. So it's remarkable how numb we've become to these deaths. And I think we're up to like 800. The U.S. is at 875,000 deaths total, which is like the population of San Francisco. So it's pretty mind-boggling. You know, New York Times, they had that front page where they showed all 100,000 names of the people that died up to that point. Now we're 10 times that many. It's really amazing. And you know, from that perspective, you know, we can see the effect of the boost of the vaccinations and the boosters making a significant impact there. And I think you know, when you talk to folks who are trying to minimize the severity of COVID, a lot of them will constantly say, well, of those deaths, you know, of all these deaths, you know, we know that they're dying of other things. Maybe they just have COVID. And while that's true, I think, you know, it's important to ask how many of those people would not have died if they didn't get COVID, because COVID was often the trigger to have the heart attack, the stroke, the aneurysm, the blood clot, the pneumonia, the respiratory failure. If not COVID in that picture, they would not have died. And we know that for a lot of different reasons. But, you know, I'd like to think one easy way to look at that is if those deaths are not COVID deaths, if they were just going to die anyways and COVID had nothing to do with it, then why is there such a difference when you're vaccinated? Why, if the vaccine only helps people with COVID, then why are we seeing so many less people die that have had the vaccination than those who have not had the vaccination? So it's kind of for me, a fairly rational way to look at that. So this is for the deaths just between September and December. And, you know, the chances of the death rate for 100,000 people, if you're unvaccinated, is close to 10. Less than 1 if you're fully vaccinated, even with no booster, which is pretty remarkable by itself. And if you've had the booster, you're even 7 times less likely to die than without the booster, and easily well over 10 times less chance of dying if you've had even just the 2 doses. So again, how is that possible if these deaths aren't truly being caused by COVID? I can't see any other way to look at that and say that those deaths that we're saying, yes, we have that many deaths, and we really do believe that they're being caused by COVID, and we have that proof just by seeing this. Similarly, when you look at the states with high vaccination rates, there's less COVID deaths, and those are the deaths that we're defining as COVID deaths. So that shouldn't be happening. The deaths between vaccinated and unvaccinated, if these were not COVID deaths, they should be the same.
Right.
In those two populations.
Doc, could you, sorry to interrupt, but could you just address, because we get this a million times in the comments,
Sure.
that people who, or the hospitalizations, they say, oh, there's 25 vaccinated, 8 unvaccinated in the hospital. So can you kind of go into, again, the explanation of that? I think we've had it explained here a few times, but just once again.
Yeah, sure. I mean, I think, your audience maybe understand this a little bit more, but, I even get providers that still point to the total numbers and act like that's a meaningful way to look at this. I mean, the gross total numbers is a completely different than looking at the rate. You've got to look at the rate. What is the denominator? How many you might have a number 5, but that's 5 out of how many in that group? So you've got a group of people that are vaccinated, a group that's unvaccinated. If the vast majority of the population is vaccinated, it's normal to see a higher number because there's just so many more of them walking around. You've got a very small number of unvaccinated people, and you have to divide by the total number that are remaining to see the rate. Rates are really the only way to evaluate and compare the two groups. You just cannot look at the total numbers. And so most states, most people that are publishing their hospitalization and death data now, most of them are incorporating that rate. And it's on the JIC report every single day. They give the total numbers, and 2 lines below that, they give the rate. And the rate has consistently been at least 4 to 5 times higher in the unvaccinated group. And sometimes it's 8, 9, 10 times higher. It ebbs and flows a little bit with the small numbers, but it's absolutely misleading, and I think dishonest if all you're doing is showing the gross total numbers. You have to put that in context with the rate. Does that make sense?
Thank you. Yeah.
This was an estimate, at least from June to November, of the number of deaths that could have been saved if everybody had been vaccinated. And this is, I think, by June. I think the vaccine was available to everybody. So the dark blue is what we anticipate the lives that probably could have been saved with vaccination. Some of them would not have been prevented even with the vaccine, but the vast majority would have. And I think the number is, between 100 to 200,000 people could have been saved. And in Guam, how does that translate? Since the summertime, I think we've had 140 or so deaths, and I think probably a good 20 or 30 of those maybe still could have died, but we could have saved well over 100 deaths, I think, if we had been able to vaccinate more people sooner. We know that the booster is also effective still against Omicron, at least for hospitalization. But what we also know, and I think a lot of people trying to minimize COVID will say, well, it still doesn't protect you from getting infected. But the vaccine actually does. I think I've said this before. It does. It reduces your chance of getting infected. And the booster does an even better job. The percent reduction. This is brand new data out of Israel, where again there was some on the forefront of vaccination. They're looking at this very closely of all infections. And I'm not just looking at the severe ones. What is the reduction in the chance of getting COVID if you've been vaccinated? That's something interesting with the younger groups, which I think is important to look at. But if you look at least for adults, you're looking at 30 to 50% reduced chance of getting infected. So how does that, how do we sort that with what we're seeing though? We just, everybody, we look at the JIC report, we see, and we know, we talk to people, this person's been boosted and they've got Omicron. Well, what we don't know, and we're not capturing is how many people that have been boosted are not getting infected. And I think that, that have been exposed. I mean, I think, at some point I'm boosted. At some point I have to think that I've been close to somebody that has Omicron, and however much distance I had between myself, whatever my mask was at that time, there may have been some viral particles, but at whatever level I was at, I was still able to prevent, hopefully, from getting Omicron. So I think that there actually are quite a few people that have been exposed, that have been vaccinated, that did not get infected. But we're seeing, of our infected, there's a lot of them that are breakthrough infections from prior infection or breakthrough from their vaccination. So, but I do want to dispel the myth that the vaccine doesn't help reduce the number. It doesn't prevent it. Absolutely not. I'm not here to say that. but it does reduce the chances of an infection if you're vaccinated. This herd immunity concept. So, if only a few people are vaccinated on this graph, on this chart here, the gray are the vaccinated and the infected are in red here. So in a poorly vaccinated place, you're going to see the infection spread everywhere. In a 30% vaccinated population, it's going to be blunted a little bit. And a very highly vaccinated population, you're going to be able to block that transmission. But the problem is where this breaks down for Omicron and COVID is that it's so highly transmissible and it infects people who've already been infected and who've been vaccinated. Thankfully, not to a severe degree, but it still allows the virus to transmit through this group over here, even when you're at these high levels of vaccination. So at least with what we know about Omicron and COVID, which I don't think we could have predicted at all, even with high levels of vaccination, I don't think we can say technically that we're going to be able to reach herd immunity with what we know right now, with what the vaccine is giving us right now. So I think there's a little danger there, and we have to be careful about using those words publicly if we're saying that's the goal is herd immunity. I just don't think that with what the virus is doing, that's actually a technical possibility for us. This flu analogy, I also think, the intent of the analogy, yes, we do have to learn at some point to live with the virus. Yes, let's focus on the more severe hospitalizations and deaths, keeping those low. It may perhaps more infections now will lead to less later. I will quibble with that a little bit, but the reality is, what's endemic for the flu, which means this always existing in the population, is not necessarily true for COVID. We definitely have substantially more people that are being hospitalized and dying of COVID than for flu. And pre-pandemic, we definitely would tolerate people that are sick in the worst place. You might keep your distance, but it was fairly normal to see people coughing and sneezing across the room from you, and you wouldn't think too much of it. Sometimes you would send people home, but sometimes they'd say, no, I got to get work done, and you tolerate it. It was something that was tolerable. But right now, there's no way we would tolerate somebody that's symptomatic and known positive COVID in your workplace or at school. Oh yeah, I tested positive yesterday, and they're coughing. There's no way we could tolerate that. And so there's a big difference there. And I don't see that changing anytime soon. And endemicity is kind of an interesting thing too. We're not really seeing COVID be an endemic type of virus and infection yet. It's so transmissible, it mutates so quickly. There's many differences between the two viruses, flu and COVID, that I really think that we have to be careful when we're using that analogy. And if you just look at the pediatric deaths, like from COVID compared to influenza, I mean, it doesn't even compare. So, I think that if you're using that comparison, I think the idea and the intent is, again, at some point, yes, we do have to learn to live with the virus, but there are many differences that we need to be clear on. And endemicity, really means that there's always going to be low levels at various places in the population. Again, I just don't see that. COVID's everywhere, and you get spikes that are high enough that, I think most people are still saying this is still an epidemic type of virus. And until something happens with how our immune system responds to this, that's not going to change. And the latest COVID news, I don't know, I haven't been able to tune in, but I don't know if you guys have been talking about the BA2 variant at all.
No, we've just been pretending it doesn't exist because it's stressful.
Oh, okay. Great. Well, it's out there. And it's interesting. It's not really a sublineage of BA1 Omicron. It kind of started a while ago, but for some reason it developed a few extra mutations that have allowed it to become a lot more transmissible. And it's competing with, it's outcompeting BA1, the original Omicron, in a few places, notably Denmark. So Denmark, here in this insert, you can see Delta is the orange, the BA2, the original Omicron BA1 is in orange, BA2 is in gray. So you can see it's actually outcompeting. I think this is up to like 70 or 80% now. And Delta obviously tailed off here. So it's potentially even more transmissible than BA1. Hopefully the severity is similarly low, but we're also seeing this in a number of other European countries. And the BA2 variant has been identified in a number of places in the United States as well. So I guess it's possible that we have it here in Guam. And curiously, I mean, we see Denmark here. So remember, if you look at their number, they're between 700 or 800 cases per 100,000. Remember, we're down here at like 400 or 500. Oh, there we are. 400. We're probably a little bit more than that, 400 cases per 100,000. So there's definitely places, Denmark and Portugal I highlighted because their vaccination rates are fantastic. I mean, and Denmark not quite as good as Guam, but Portugal is like 85, 90%. So even with highly vaccinated countries, you're still going to get a lot of cases, again, preventing the severity of disease, but lots of cases. What's interesting is Denmark has said, record cases, we're going to cease all COVID restrictions. So I think there's this is a country that's done very well, and they're looking at what's happening there, and they're saying we're not that concerned about what we're seeing there with the cases. So this is an example of them saying, of a country that's saying we need to learn to live with this. We're not going to place a whole lot many more restrictions because we don't think the fallout's going to be that bad. So I thought that was very interesting. So just to wrap this up, our take-home points. I don't think herd immunity is technically possible right now with the current rates of reinfection that we're seeing from people that have been either previously infected or have been vaccinated. The flu analogy, I think it's nice to focus on the intent, but it is somewhat at odds with what we are seeing with COVID. We're about 78% fully vaccinated in Guam and 38% boosted. I thought that was actually pretty decent. It was a little bit of improvement the last time we talked. The 2-dose vaccine, even if you're not boosted, thankfully is still holding up fairly well against severe disease and death. But you can certainly increase that up to 7-fold if you're boosted. So get boosted, people, please, if you're not already. And it's not too late, even if you're not vaccinated, to get that vaccine. I think there's definitely still benefit to it, even if you've been infected before. Vaccination does reduce the infection, but it doesn't prevent it. And it's not well enough for us to prevent continuing spikes like this. So I think I just read something this morning about one direction that might help us significantly is a type of vaccine that is mucosal. You spray it in the nose and it develops antibodies in the mucosa so that when you're exposed to the virus, it can't get into your airways any farther than that. And that would be, we need a vaccine that will help prevent infection and transmission. And I don't know how close we are to that, unfortunately. That may still be a year or more off. And what I also know that Pfizer is testing their Omicron version of the vaccine, but those study results won't be out till after the summer. So, in the near future, even the next 4 to 6 months, I don't see a whole lot changing. We're going to be sort of at the mercy of Omicron and whatever variant comes after it. Thankfully, I think right after we spoke, the president announced that they're going to be shipping a whole 4 rapid tests to everybody. So I applied for mine, and I hope everybody else did too. Just one more tool that may help you decide if you're currently infected and contagious. We have received some antiviral agents. I don't know if that's been discussed on the show before too, and that Pavloxid, and that certainly will help us prevent folks from having more severe disease. And I think I see a 6-week surge. We're about midway between that. So I'd like to think we're peaking now. I'd like to think we'd keep our hospitalizations below 60. And we're probably again at our peak in terms of cases per day. But you talk to some of the doctors and the clinics right now, and they're still seeing tremendously high number of people coming in for testing. And at their clinics, at least, they're seeing like 70, 80% positivity. Guam's overall positivity, I think, is still 20, 30%. And that's actually not as bad as what we're seeing in some other places. So I think the folks going to the clinics are probably more symptomatic and have a higher chance of testing positive. So.
Yeah, Dr. Hoa told me yesterday at their clinic they had 80 to 90% positivity rate.
Yeah, he mentioned that in our chat too. That's astounding. Again, I think it's a little bit skewed. The type of people that are going to be going to the clinics are the ones more likely to get tested positive. But if you're going to the free clinics, you maybe don't know, or you want to just be on the safe side, or you want to let your work know. So some of those folks may be maybe less symptomatic. And that was one of the slides from Dr. Babuskis too. The percentage of the positives that are symptomatic, it's actually fairly low, a little bit surprising, but I think even though there's this desire, intent to communicate a message of let's learn to live with it, it doesn't mean we're saying let's just let it rip. We're not saying that at all. I mean, I think that there is definitely there's an impact, even though Omicron is super transmissible. There's definitely an impact of wearing your mask, keeping your distance from people. So, and the isolation protocols, whether it's 5 days to 10 days, there's an impact there as well. It's not negligible. It's not zero. It's probably not a lot, but it's, even if we can make a 15, 20% dent in in this current surge, I think that's worthwhile, and so it's still worthwhile for us to continue to push in that direction.
Doc, what are you hearing about that Paxlovid and the Molnupiravir?
Let's jump. Doc, can you just hang on? We're going to jump over to KUAM TV just real quick. And I know we had just a couple questions about your presentation. 804, we're KUAM FM and Gotney Guam on the breeze. KUAM TV, here we come. Guam. It is Friday. KUAM TV, Bananas of Zeus. Good morning, Sabrina.
Good morning.
Good morning, Jason.
Good morning, everybody.
Good morning, Joe, sir. We got our 8 o'clock news coming up. We've got the Minority Report with Minority Leader, Senator Chris Duenas. And also, we've got your governor in the CNMI, Governor Ralph Torres, coming up 9 o'clock right here on the link. I think it's going to be good. We've had pretty much every elected leader from the CNMI except the governor on recently, so we're excited for that. It's 8:06, in progress with Dr. Peter Lombard, who's crunching COVID stats. Just did a great presentation that will pop up on YouTube after the show. But Sabrina was just asking about the antiviral, the
antiviral pills, the Paxlovid and the Molnupiravir. I was listening in on a portion of the interview that Daniel was doing with Dr. Nathaniel Burr, the Physicians Advisory Group. And during the interview yesterday, he was mentioning that they were working on the protocols, guidelines for the administration of these two antiviral pills. And they were going to be providing it to healthcare providers, and with the possibility of seeing these being administered today, possibly. So I wanted to ask Dr. Lombard, what are you hearing about these pills? Who can take them, who can't? Because from the interview with Dr. Berg, he was saying, well, if you have extreme liver disease or renal issues that you, like if you're on dialysis, you wouldn't be able to take these pills.
Yeah, that's a possibility. That there are some significant, not insignificant side effects that can happen, and we do have to be careful about who we give them to.
Yeah.
It's also, as you know, it's not designed for inpatients. It's really designed for outpatients. You want to treat people soon after they're diagnosed, and so there is a fairly narrow window. And I think that if we had enough of it, it's best to put these in the hands of primary care clinics. I think because it's outpatient. You want to give these to outpatients, and that's the goal. But reality is we just don't have enough of the medicine. I mean, it was pretty amazing to hear how few doses we have. So I think they're being careful, and I think that the decision to kind of control the supply from GMH, I don't think that was a horrible decision. And to make very clear what the policy, the protocol is to be able to use these and make sure we're using them in the right people to get the best bang for the buck with the limited resources that we have. But definitely these are really amazing based on the studies that we've seen so far. Really phenomenal treatment options that we have.
Mm-hmm. What are the studies showing?
I'd have to look it up. If recollection serves, it's very high, 80-90% reduction in severity of disease, something like that. So it's you tack that on to vaccination too, and I think that what this is going to do is, if we're treating people appropriately, we're going to see even less hospitalizations and deaths of the people that are testing positive that looks like they're trending towards more severe disease. So I think if we had access to as many as we could, the impact would be greater. But because we have so few, I don't know, it's going to be difficult to, I think, prioritize. I think if you have a hookup, for example, with a doctor or something, and you test positive, we don't want to see that happening in terms of who's getting it. Somebody with more comorbidities that still qualifies should be the ones that get the limited supply.
Are you hearing that these pills would only go to vaccinated individuals or unvaccinated?
I'm sorry?
Are you hearing that these antiviral pills would be administered to only vaccinated individuals?
I doubt that. I doubt that would be the case.
Okay.
I glanced at the protocols, the tentative protocols. I think that, I don't know if they're finalized yet, but I don't remember seeing anything about that. I would be shocked if that was part of the protocols, only to give it to vaccinated.
Doc, do you think we're at a level where we don't really have to be concerned with the Delta variant and RegenCov anymore?
I really think, of our cases, I guess less than 5%, maybe even less than that, or less than 2-3% of all of our cases are Delta right now. So most of them clearly are Omicron. So I think that phase is behind us. But this is the enemy we don't know as well, and the next enemy is going to be one that we have to learn about more again. The pattern of this coronavirus is this COVID-19 has been rapid mutation and then a new variant that we have to figure out almost fresh.
Doc, Dr. Berg, Physicians Advisory Group said with a little luck that we could come out of this surge by February 1st. I know that you had said you're looking at it lasting a little bit longer. Could you kind of just address that and then also address this the messaging from public health and the governor that this is kind of a mild surge? Because I think people are having a hard time seeing these crazy numbers and equating it to something mild.
Mm-hmm. Well, it's mild from the standpoint of comparing it to the previous wave. It's mild. The severity of disease, the number of people in the hospitals, it's nowhere near what we were seeing before. It's not mild as a bad flu season yet. Okay, so that takes it in context. I think the messaging is difficult. They're trying to balance not making people panic too much with also making sure people are still worried enough that they're still willing to take the appropriate precautions. And so I think people want to have sort of this all or nothing mentality. It's something to worry about or it's not something to worry about. And no matter what the governor says, the PAG says, that tries to find a balance, people are always going to say, oh, well, which is it? Is it all or nothing? Because it sounds like you're saying all of this or all that. And I think that's just I don't think it's a very healthy way to look at it. I mean, I think there has to be a middle ground. And I think that even an effort to maintain some of our policies that are trying to prevent this let it rip philosophy, I think it does have an impact. And I think it's still worthwhile. So
would you say that we are in effect, practicing the let her rip philosophy right now?
I based on what I see, I'm still pretty impressed. I mean, you can see the concern on a lot of patients' faces when they come in. A lot of them are double masking, and they tell us if they see something in the clinic that they felt like, oh, it was a little bit crowded in there the other morning. And so and maybe these are just select few, but in taking the pulse of the general average person out there in Guam, I think that they are still concerned appropriately enough, and that they are being careful. And I think that has made a difference in terms of how bad this surge has been. I think it's too optimistic to say this is over by February 1st. I mean, I think just looking at, it's going to take 2 to 3 weeks for us to come down from where we are right now, even if things started making that U-turn, which is what we really hope that we're going to see over the next few days, over the next week. But there's no way that those case numbers are going to go down to zero in just a few days.
Thank you, Doc. Always great to have you on. Appreciate it so much.
Thanks, guys. Happy Friday.
Okay, there you go, Dr. Peter Lombard. Jay, we put that up on the YouTube after the show, right? If you guys want to, I mean, he did a whole PowerPoint. It was about a 30-minute presentation. And he pulls this data from national, international sources, as well as public health's own numbers, and kind of crunches them all and does all the graphing and the charting. And there was some stuff in there about the new variant.
And the comparison is very much appreciated, when you say, like, here's where we are, like, on here's how we rank, like, globally, or here's, like, at scale.
Right.
Here's how Guam's doing, for better and worse. And we mention this all the time. You guys follow Dr. Lombard on Twitter. He's at Peter Lombard and everything like that. If you like what he's doing, this is literally just a snapshot of what he does. He shares really good information from other physicians, from other data sources, people who do what he does and everything like that. And if you want that kind of like analytics approach to see how we're doing and where we could be, everything, he's a great follow on Twitter.
Yeah, yes, definitely.
Especially around football season too.
Thorough and easy to understand.
That's what I really like. Very easy to understand. Super layman's terms, like a friend told me once. Thank you, Doc. Right on. We got to ask him about the Blu-ray blockers next time. 8:14. It's Friday, January 28th. We got our